Um, on Mighty Networks, we keep slides and any resources discussed. The way the format works is we'll have each of our organizations present. They normally present about 20 minutes or so. Of course, if you have questions, please just type them in. And what we'll do in the latter 20 minutes is have time for Q&A and discussion. For speaking order, Equality Health, are you all okay to present first, or do you need to wait for Nora to come on? And I'm sorry, Nora, if I can't see you.
Thank you, Wes, and good morning, everyone. If it's okay, and Nora I just forwarded her the formal email because I think we had a couple of the holes on the calendar. So she may be trying to get logged in with the official invite. If it's okay, if we
No
maybe start
problem.
with the
Yeah.
first and then gives her time, if that's okay with
Okay.
the other
All right.
speakers.
I will go ahead then and pass it over. So we will have Dr. Um, Wesley McWhorter, and I'm a big fan of the first name for obvious bias, but Dr. McWhorter is a professional chef, registered dietitian, behavioral scientist, and food as medicine expert. Currently vice president of lifestyle medicine at Suvida Healthcare, he also serves as the national spokesperson for the Academy of Nutrition and Dietetics, an advisory council member for the Teaching Kitchen Collaborative, and a community board member for the American Diabetes Association. Dr. McWhorter is dedicated to advancing hands-on culinary medicine education and Buddhist medicine programming, focusing on promoting nutrition equity. He frequently publishes academic and practice-oriented research, contributes to textbooks, and has authored an award-winning cookbook. Wesley previously served as assistant professor at McGovern Medical School and the University of Texas School of Public Health, where he was also the director of culinary nutrition for the Nourish program. Wesley received his culinary training from Florida Culinary Institute, his undergraduate degree from Kansas State University, his master's from the University of Texas Medical Branch, and his doctorate in health promotion and behavioral sciences from the University of Texas Health Science Center School of Public Health here in Houston. Without further ado, I'll pass it along to you, Dr. McWhorter.
Thank you so much, Wes. And that's actually pretty funny to be seeing Wes and Wesley. And when I'm seeing these emails go back and forth, I'm like, is that to me or is that to Wes? And I don't know, people shorten your name to Wes or Wesley. So either way, funny to have those connections. But appreciate y'all having me on today. As Wes said, my focus is on food as medicine. So I'm not going to cover the whole gamut of value-based care. The next group obviously will have multiple things to touch on as well. I'm going to touch a little bit on Suvida, the company that I work for and represent. And I'm going to describe a little bit of what we're doing with our Food RX program. So food prescription, which I know many folks on here are familiar with, having worked in the Houston Food Bank, et cetera. And I see some familiar faces, some familiar names. So really, really great to see many of you. I wish this was in person, but I will go ahead and share my screen. I do have a video. I'm hoping this sound will work. I haven't been on Zoom in a minute. So if it doesn't, then I will share that separately otherwise. And just by like a show of hands or emojis, I think we can do emojis in Zoom. Who's familiar with value-based care? Just like everybody who's familiar with it, give me a hands up or a thumbs up in the chat as well. So we have a good amount of people, some that are not. And the way I would describe it, just to give a 2-second review here is, traditional medicine, and no offense to the folks that work in traditional medicine, but the vast majority of what we're doing is we're charging fee for service. And with fee for service, a lot of the things that would prevent or keep us healthy are afterthoughts. And as a dietitian, nutrition is really important, right? We know that the vast majority of, chronic conditions have a connection to what we consume or what we don't consume. But there's not a lot of money in it, right? There's not a lot of money in preventing conditions. There's not a lot of money in providing these items. So if you flip the script and you say, you know what, now we're going to pay companies to keep people healthy, that changes the narrative around nutrition, around physical activity, around these behaviors that we're going to be talking about in a minute here. That really, again, companies like the one I work for with Suvida, other value-based companies can really focus on and incentivize, are incentivized to really push into change. So Value-based care, full risk model, when patients end up in the ER, that means that we are at risk for that, right? So a lot of the focus with companies in the value-based space is to really focus on how can we keep our patients healthy, right? It's not okay that we just do procedures. It's really about the improvement of that. So for us, our goal again is not just to focus on whatever procedures we can do, but really to focus on how we can keep our patients in a healthy state. And within that, we believe that health equity is one of the biggest fundamental pieces to make that happen. Our patient population, primarily Hispanic, and we know the data would tell us, everyone that's part of this group knows that these folks have been left out in the cold, I would say, for the vast majority of time. So how can we not just say, here's healthcare, but how can we do healthcare in people's preferred language, with providers and with teammates that, speak the language, know what foods people like to consume, et cetera, et cetera. All of these things really play a big factor. Within that, when you come into a Suvida center, we're primary care, but we also are integrated primary care. We're not just, providers. We also have pharmacy. We have dietitians. We have PT. We also have a role which I think would be an excellent presentation at one of these next meetings, which is our GIA team, our patient guides. And they really spend the vast majority of their time focusing on SDH needs, or as we refer to in Texas now, which I was told is non-medical drivers of health. So we have a very integrated team that doesn't just focus on, hey, let's do traditional patient care, but really what's outside of the four walls of the clinic, and how can we ensure that these things are thought about, that we address them, that we also connect the dots. So with that, my title, lifestyle medicine, some of you might or might not know what that means. To give a summary, lifestyle medicine is not the replacement of traditional medicine. Very important that we're not saying that if you eat broccoli, you don't need a doctor. That's ridiculous. Just as much as the terminology of food as or food is medicine, we don't want to get caught up in that terminology too much. But the fact that food does impact the way, your health, either, if you consume healthy things or if you don't, it will impact your health one way or the other. And that's really, if you viewed lifestyle medicine, it's the health behaviors. And that's what that graph here on the screen is showing. And over on the far right side, there's these 6 pillars of lifestyle medicine, which is really what you consume or eating well, how much you move or don't move, avoiding risky substances, stress, which I'm sure some of y'all were stressed out driving on the roads when it was icy a few days ago. Anybody? A few, show of hands, maybe not. Maybe you didn't drive. Hopefully you didn't. You were smart and stayed home. Another one that we're seeing that was such a huge impact when it comes to during the pandemic was social connections, right? So we realize how much our health is impacted when we connect with people or don't connect, right? That's a massive thing. And especially in our senior population, we know that people are isolated, their health is going to decline. The last one here is how much we sleep, right? And are we sleeping well? Did anybody stay up too late last night watching Netflix or streaming some TV show or scrolling LinkedIn or, I don't know, grading papers or something? You're impacting your health, right? Versus flipping that and turning around and sleeping well. So we have these health behaviors, but what we also know is that health behaviors, they don't exist in a vacuum, right? Just because we tell someone to eat healthy, is that going to work, right? Any docs on this call, have y'all told your patients to eat healthy and did it work really well? I see Dr. Perkinson's on here. I don't know, maybe, I know there's a few docs on here, but if you tell your patients, hey, go eat healthy, it's not just going to happen all the time, right? There might be some barriers, and we all know this with the SDH factors. So with that, I like to look at this patient pathway and why this is important. And I promise you, I'm gonna circle into what we're doing and how this connects. But if there's this typical diagnosis, we send the patient for a referral to nutrition, whatever it might be. The most often thing we see come back is the patient is non-compliant, right? They didn't try hard enough. They just didn't do it. We told them what to do, but they didn't handle that advice. Just like all of you, statistically speaking, 90% of you on this call didn't eat enough vegetables yesterday. I could say, well, why didn't you do that? You know, you knew, right? You knew you should do it, but there's other reasons behind just simply knowing and not knowing. So telling someone to just pull themselves up by their bootstraps and try harder is not going to work. And for us, again, in the value-based care space, it's fundamentally very important that we don't just wait for people to be really sick. We have to focus on, you know, primary, secondary, and tertiary prevention, because these are the ways that we can really improve our patients' health. And, you know, that's the way we should be doing it in general anyway. So, you know, with that being said, we can screen, you know, for SDOH needs, you know, over on the left side, you know, we have SDOH needs, and then we screen, just like I would assume vast majority of y'all are doing right now. We do as well. We screen for SDOH needs, we screen for, you know, nutrition security, food insecurity. We also can then offer food or X. But if you notice here on the screen here, I have a, you know, it doesn't always equal just healthy eating, right? There's more that goes into this. There's more that goes into how can we make this work? And what we do with our model is, and I think the model that we do is really focused on the research that we completed at UT when I was there. And I'll get into that here in the next slide. But I have a question here for y'all. Healthy food. What do y'all think of it when you think of healthy food? Is it a positive experience for y'all? Just by showing some people, yeah. What about your patients? Do you think it's a positive experience for your patients? What do you think they think of? And if you've heard me speak, you know what's coming next, right? You know it's gonna be the sad salad, right? I'm the sad salad guy. If you didn't know that, now you know. Why this is important is we're trying to sell nutrition, right? We're trying to sell healthy eating to our patients, and at the end of the day, that's what it is. It's sales. And if it's a negative thing, if it's punishment, then people don't want to do it. If it's a nasty salad, if it's boiled Brussels sprouts, quite frankly, it's just not going to work. So how do we flip that? Is we start talking about the joy and pleasure of eating. And if you just think back, if you're a doc or not a doc, you think about your parents, somebody that's, you know, struggled with diabetes, heart disease, obesity, whatever it might be, going to the doctor and talking about that is not a joyful and pleasure experience. It's usually told with, I have diabetes, I no longer get to enjoy anything in my life anymore. And when you say it that way, it really takes, you know, it takes a few minutes to be like, you know what? I can see why people really wouldn't want to do this. It's punishment for the rest of your life simply because of a condition. So rather than doing that, how can we flip it, focus on what we like and what we enjoy, and find, you know, a space in there to improve people's health and improve what people are eating? So with that, what we do is we focus on this method here that I was mentioning, which is the taste, see, do model. Remember, whenever someone walks through the doors of a clinic and we're saying eat healthy, they think sad salad. So we have to flip that by offering a tasting experience. A tasting experience is something that's very positive. It opens your eyes to say, oh, I really enjoy this. It's not simply about a negative experience. The next piece is seeing how to do it. A lot of us, you might like something, but if it takes me an hour and a half to prepare it, I don't have time for that. I can't do that with my family. And then the third piece is you actively actually do it so that you build those skills. Remember, the vast majority of patients that we're working through with conditions, they have, you know, had a condition. If they're 65, they've probably been eating this way for, I don't know, 30, 40, 50 years. That's a lot of behavior time that's been built up. So it takes time to change those. I use the example of kids when they're learning to walk. Anybody that has small children and their child's learning to walk, the first time they fell down when they were trying to walk, did you just go, you know what, give up, forget you, you're never going to learn how to walk? Did anybody do that to their kid? Absolutely not, right? You stand beside them, you help them, you know, oh, you can do it, you know, make sure it's soft here, don't try this on the concrete, you know, you're keeping them safe. You're normalizing that it's okay, right? You will get it. The thing we don't do with our patients is we don't do that. We shame, we humiliate often. We make people feel bad because they're not able to, achieve that success right away. So it's important that we really normalize that. And normalizing that looks like, you know, when I'm cooking this, it didn't work out for my family, or I didn't like the spices, or one of them burned and one of them didn't. How do I fix this? Or, you know what, Wesley, I hate kale. What else can I eat? It's just simply walking through these procedures, and that really makes it easy. So I say all that to wrap into what do we do? And I have a video, so I hope it'll play sound wise. If it doesn't, I don't know, but it's about 2 minutes. This just gives an overview of what we're doing at Suvida.
Are you ready?
Can y'all hear that?
Everyone, my name is Javier. I'm a dietitian.
Yes, we can hear it.
Yeah. Really passionate about what we do here. We know that food is integral not only to our day-to-day, but also to our culture, to our family. It's fundamental to Suvida, and I mean, honestly, healthcare in general, that we're not just bringing patients in to take from them, we're bringing patients here to serve them. One of the ways we can do that is through food, and food is one of those pieces that really connects people and brings people to the table.
Today, we're giving some free food from the food bank to all the patients and people who are in need to help them with their good nutrition.
I'm the Health Partnerships Manager at the Houston Food Bank, and today we are launching our FoodRx program with Suvida Healthcare. And FoodRx is basically a way to ensure that patients have nutritious food and education to help them manage their chronic conditions.
I think it's really important that our patients not only take care of themselves well with medicine, but also with food, making sure they have healthy food, fresh food every day to prevent any type of heart issues, improve their diabetes, their hypertension.
My favorite thing about Suvida is the people that surround you. They talk to you very nice, they're kind. They'll help you with anything you need.
We love coming to Suvida. They give us a lot of attention, and that's real important for people our age.
Hispanics tend to have a high prevalence of diabetes, hypertension, high cholesterol. So having a healthy food and having the proper way to prepare the food that is cultural sensitive, so you get the adherence to the actual new lifestyle, makes a lot of sense for us at Suvida.
There's a lot of us that don't understand English. We know more Spanish. And they don't criticize, they help you. That's good that they're fighting. That helps a lot of people out.
We learn what is it that we need to do to keep up with our health.
We want people to not just, hey, eat healthy food, but eat food you love.
We have recommended people to Suvida, and we'll continue doing that.
Thank you very much, Suvida, for helping me out with the little groceries and being so kind and patient with us.
And we appreciate everything you all do for us.
You can find out more about the next events by finding us on suvidahealthcare.com or on your next appointment, ask your provider to get you more information about the events that we're going to have.
All right. So, with this being said, whenever we're doing our FoodRx, we don't want people waiting in line for an hour and a half, 2 hours, right? So we set up appointments just like many of y'all do. I know this is not completely novel to everybody else, but just in the scope of value-based care, we're not a nonprofit, right? This is a for-profit company. We believe that this is fundamental to improving our patients' health. It's the right thing to do, right, as well. And then also just it makes sense. One thing that we, if you know me, I fundamentally believe that, whenever we do food, it should look good and taste good. So when we do it, it doesn't have to be nasty simply because it's a distribution, right? So this is just pictures to illustrate, the beauty of what we can make out of things. The team building experiences that we got out of this as well. So that, any of y'all that do this know it's a lot of work. But we host these in our centers with the Houston Food Bank in the Houston market, doing distribution. We have our patients come in, they get a cooking demo. There's also nutrition education, and then the food distribution happens. So our patients are there about a 30 to 35 minute window. And they're in and out with all the things that we're really trying and wrapping around to do. So this is in the Houston market. Our centers, we also have Austin, Dallas, Tucson, and Phoenix, and we're doing these as well in our other centers. Again, as a way to help overcome some of these barriers. As I mentioned, many of our patients are struggling with these chronic conditions. This is just simply one way, one example of how we help overcome that. So if there's any questions, I think we'll take them in at the end. I want to make sure there's enough time for the next group. And again, just sharing a little bit here of what Suvida does with the FoodRx model. And I would love to invite other team members, especially our GIA team, to go over really the focus and everything that they're doing with with social determinants of health, non-medical drivers of health, and helping our patients. So thank y'all for listening. I appreciate it.
Thank you, Dr. McWhorter. All right, well, I'll go ahead and introduce our next group. We've got 3 speakers from Equality Health. All right, our first is Dr. Sherri Onyiego, the Texas Medical Director. Dr. Onyiego serves as the Texas Medical Director for Value-Based Care Leader Equality Health, where she engages and supports primary care practices across the state to advance value-based care models to patient populations with socioeconomic barriers. Prior to this role, Dr. Onyiego was part of the executive leadership within Harris County Public Health in Houston, serving as the Director for Nutrition and Chronic Disease Prevention, focusing on promoting chronic disease prevention efforts in the community. Dr. Onyiego is a board-certified family physician with over 15 years of clinical experience in managing and treating chronic diseases as it relates to individual patient care and population health. Dr. Onyiego earned a doctorate in pharmacology from McWhorter Medical College in Nashville, Tennessee, with a research focus on novel compounds targeting HIV-1. She attended medical school at Ross University School of Medicine and completed her residency training in family medicine at Louisiana State University Health Science Center, and later went on to conduct a fellowship in HIV medicine at the University of Texas at Austin. Dr. Onyiego has a passion for public health and addressing health inequities and currently serves on several local, state, and national committees, work groups, and boards. All right, and then our other speaker will be Bellot-Hanson, Director of Health Equality and Community Partnerships. Lauriane serves there with Equality Health, which is an Arizona-based healthcare delivery organization where she leads the company's blueprint to eliminate health disparities. She aims to build bridges in siloed health and social services landscapes to meaningfully address social drivers of health through sustainable and authentic community partnerships in order to improve health outcomes of historically excluded communities. Lauriane carefully applies herself in grounding her efforts in equitable, culturally responsive, and community-centered approaches. To ensure she anchors her work in the needs of the community she serves, Lauriane is actively involved in a variety of health and community initiatives, including local health improvement plans, her home state public health association, and serves on the board of a local community action agency. Lauriane holds a bachelor's in administration and international politics from, I'll try and pronounce this in French, Université Grenoble-Alpes UGA, a master's in health administration sciences from Northern Arizona University, and in many MBA in health administration from the University of Arizona. And our last speaker, Nora Lozano, serves as Community Engagement Health Director with Equality Health. With over 15 years of healthcare experience, Nora focuses on implementing initiatives for diverse populations. As the Community Engagement and Health Director at Equality Health, Nora leads a dynamic team of community health workers and chaplains across multiple states, emphasizing holistic patient care and addressing social determinants of health. Her team focuses on supporting high-risk patients, enhancing access to quality care, and reducing cost-based care model. Laura's early work in prevention, particularly youth substance abuse prevention and mental health stigma reduction, showcased her dedication to positive community change. Her commitment to the community health worker model underscores her advocacy for health equity. Nora currently serves on the board of Arizona Community Health Workers Association. All right, and without further ado, I'll turn it over to you all.
Thank you so much, Wes. And we really appreciate the opportunity to be a part of this discussion. Thank you, Dr. McWhorter, for that fabulous presentation regarding the work that you all are doing at Suvida. And it's really a pleasure to really be on the call amongst friends and colleagues in the virtual room. So I am just really going to provide a very high-level overview and really yield my time to my esteemed colleagues who are on the call from Equality Health, because I really think that the work that they're doing, specifically as it relates to how we're engaging with the community and patients that we're serving collaboratively with our provider partners, and also the broader community to address health equity. I think that you'll really find the work that they're doing quite fascinating. So again, thank you so much for the opportunity. Lauriane, could you go to the next slide? So just to provide a very, very high level overview of the work that we do at Equality Health, we are a tech-enabled primary care platform. We leverage a number of we leverage value-based payment models to really help to transform healthcare for diverse populations. We often refer to ourselves as unapologetically Medicaid first, and I think that oftentimes you may not hear value-based care and Medicaid in the same conversation. So I think that we certainly are leading the the value-based field, if you will, in the fact that we are leaning in first with truly serving a Medicaid population and really trying to center primary care providers around value-based payment models to support that population. Recognizing that this population certainly has unique challenges. Historically speaking, they're faced with a number of challenges, as you all know, access to care, fragmented care, continuity of care. Those are all barriers that certainly are really impacting these populations, and it certainly plays into some of the utilization patterns that Dr. McWhorter was talking about with utilizing the acute care setting, whether that's ER or recurrent hospitalizations. And so we're certainly focused on really trying to ensure that our model is rooted in really trying to break down some of those health inequities and structural barriers. If you go to the next slide. So our current footprint is really established here. You'll see the map. Right now we have over about 3,000 provider partners across the multiple states that we're in. We have a national footprint. We started our work in Arizona as our flagship market about 6 years ago, and we've been in the Texas market since 2021. Tennessee was our latest market that came on board about a year or so ago, and most recently we have introduced our market and our platform and our model in Louisiana and Virginia. So we're certainly excited about that and have a number of other emerging markets that are also in the pipeline. Across all of our markets, we have about 700,000 attributed lives. And then if you could go to the next slide, Lauriane. So really at a high level, what we do is essentially, again, I want to underscore the fact that we're really doing this work in a Medicaid space. It certainly has applicability to a number of other populations in our Arizona market where we're certainly more mature. We do have a Medicare line of business as well as Marketplace as a line of business. But in our existing markets and our emerging markets, we always lean in first with a Medicaid first in terms of our reach and the population that we serve, and recognizing that it's very difficult and hard work. But just at a very high level, this is essentially how we're able to operate and do the work that we do. So we first start off by sourcing value-based contracts with a number of sponsoring managed care organizations. We leverage some of those relationships into other states as we go to different other states and set up new markets. But certainly we have to source those contracts initially with our sponsoring managed care organizations that we have upstream. We're able to recruit a number of primary care practices that we're able to essentially congregate and sort of put in our regional physician network at Equality Health. So we don't own any of these practices. They're diverse in scale and scope. Some of them are independent practices, academic practices, federally qualified health centers. But we recruit them all, and they, as a part of our regional Equality Health Physician Network. And then what we're able to do is integrate data from multiple different sources, whether that's from the payers, whether that's from health information exchanges, whether that's ancillary vendors, and also from our providers. And we turn that data into actionable data, essentially that we can sort of put in front of our providers that really sort of ties back to quality measures that they can focus on, that really essentially ends up being care gaps and care opportunities for them to address on a preventable perspective. We equip our providers with a number of different tools, ultimately to help improve overall outcomes. We have a number of tools that I'll briefly touch on. One is our technology-enabled platform. We also have an activity-based financial incentive that we support our practices with, and then we also support them with human resources to really help them with efficient workflows that they can embed into their practices. We also have a number of care team supports that further wrap around the practices and also directly engage with our members that we're serving collaboratively with our practices. And that's what Nora will talk a lot about, because that's the team that she oversees. So all in all, with our operating model, ultimately what we are trying to do is drive value for our stakeholders who are our managed care organizations upstream. We capture some of the share of the value that's created. And ultimately, our goal is to improve quality and reduce the cost of care within as it relates to the population. So next slide. So this really just illustrates our overall care model. We certainly have multiple different approaches to ensure that the needs of both the provider groups as well as our members or patients that providers are serving are met with the end goal of like I've said, reducing cost for the care of those members and patients, and then also improving the quality outcomes from a preventive care perspective, as well as as it relates to chronic disease management. So essentially what we'll do, as I mentioned, we start off with ingesting multiple different sources of data that longitudinally tracks the member. So we ingest payer data, which talks about an individual's members' eligibility. We ingest quality data as it relates to a population. We ingest claims data. So we have a number of different insights that we can certainly track over time that really gives our provider partners a different sense of what's happening with that with that patient. We also take in tertiary and ancillary data, as I mentioned. So some of that could be health information exchange data. So across the state, we are connected to a number of local and regional health information exchanges. So we're able to really see when members are accessing ERs and hospital systems, and we're able to put that insight in front of the provider so that they have real-time information and access to knowing when their patients went to the hospital or went to the ER so that they can get them back into care to help reduce downstream readmissions. We also take in, as I mentioned, laboratory data, pharmacy data. Also, that provides a different view or access to information for the providers that they may not otherwise have, particularly if patients are accessing ancillary vendors outside of that provider's health system. And then we also take in a number of different outpatient data. And so we're able to do data integration directly with a number of our practices. That direct data integration really allows us to be able to access unique information and data regarding our individual members. So whether that's information about demographics, whether that's information about race, ethnicity, language, if our practices are doing various screenings and especially around those non-medical drivers, we have access to some of that information, and some of that information we certainly can share upstream with our payer partners who may not otherwise have that type of insight. And so a lot of that information and data that we're able to really take in is, again, as I mentioned, fed directly into our population health tool, which is proprietary. It is practice facing, but it's not individual provider driven. So it's really meant to be a tool that a practice's front office staff or back office staff can access to help understand who their population is, who their patients are that need to come in on a more frequent basis because they may have multiple or complex chronic conditions, or they may have patients that need to come in on a more preventive care basis. So we put all of that insight and make it visible in our population health tool. So it's really more designed to be an adjunct to an existing electronic health record that a practice has, certainly not to be something that a provider is doing double work into. And then I think a big component of our model really does lie on the practice transformation work that really has to happen when you talk about value-based care. Again, we are enabling our primary care practices that are in our regional networks. We don't own these practices, and so a lot of the work that we're doing is really enabling them with practice transformation workflows. It's not enough for us, and we know that it's not just going to be enough to just go in and give someone access to a technology tool and think that transformation will happen. So a big part of our model is really helping to empower and enable our practices with hands-on support for practice transformation workflows, whether that's pre-visit planning, best practices on huddles and managing patient lists, and identifying who higher risk population patients are to get them in on a quarterly basis. And so a lot of that happens with our practice transformation efforts that we're doing. Another huge component of our model really does rest within our direct member or our community facing approaches. And so I'll I know that that's what Lauriane and Nora are going to be talking about. So I do want to provide time for them to really tell you more about that work. But a lot of the work that we're able to do with our community facing and our direct member components of our model does allow for us to be able to have field-based teams that are directly deployed into the community, directly engaging with the practices. We recognize that a number of our practices may not have community health workers or care specialists who can navigate patients to different things like community-based organizations for food, for housing, and for things like that they're really facing that can serve as barriers for them. So, Lauriane, if you can go to the next slide, I think that may be it, and I can turn it over to you all.
Thank you so much, Dr. O. So our field-based team, like Dr. O was saying, we have a multiple component, right? We have our practices and we are enabling them with tech systems to be able to attend and manage their population. Though our direct member approach allows us to deploy these other resources from our company to proactively address those members or those patients that are higher risk. And not only that, but also we are able to do prevention and in complex care, right? Prevention, complex care, and in transition of care. So these are some of the parts that you are going to see here. The prevention part, it's we are able, with the data that we have, we are able to see who has what opportunities, and then we tackle that. We have our care specialists that are more in the digital space, doing the outreach and the assessment and the interventions digitally and on the phone. Our team, it is member facing, but it's also field based. So we are community health workers, chaplains, and in some states we have the component of the complex care nurse practitioners that are able to support those members that are at a higher risk. In our population, it's around 35% of those members are in the higher risk that they have multiple chronic conditions plus social insecurities that are preventing them to reach the full potential that they could reach in order to recover, to adhere to treatment, and to feel supported in their own communities. So and if you want to go to the next slide, Lauriane, please. Yes. So what I want to tell you is how we do it, but presenting you two different scenarios, different stories of how we approach our members. So UPCON, we have different buckets of work, if you will. We have what it's transition of care, and what we say everything else, right? It could be referrals from PCPs, referrals from our payers, internal referrals from other members in the team that have come across to a patient that needs a more hands-on support and that need in-home or face-to-face support. So upon, like say for the transition of care upon their discharge, and oftentimes we can even start the outreach when they are admitted. So our data indicate us that a patient has been admitted to the hospital, and we have community health workers at the hospitals visiting the patients and engaging at bedside, so we can start the process to ensure a smooth transition of care when they are ready to be discharged home. So we start that engagement. Of course, not all the time we are able to engage these patients, whether they were discharged before we were able to meet them at their hospital, or we just couldn't engage for one reason or the other. Those go those go discharged home, or skilled nursing facility or other facilities, and our team outreaches and engages. For example, the first situation here, we had a member that was facing challenges after an early diagnosis of Alzheimer's, right? This patient was discharged from the hospital. That was the reason for discharge, all these complications, and he realized that was his diagnosis. Earlier, he had done the paperwork for to be the policy holder. He couldn't remember what he did, where he purchased this policy, and he was in distress. This distress was causing for him to not be able to adhere to his treatment, and also he was n- not able to follow up his treatment because he didn't know where to go, things like this. When the CHW came on board, was able to support the member, right? Was able to go in and have go to their home, see the paperwork, find out who was that they had done uh, the policy. But not only that, he was able to provide group supports, chaplain assistance, find an MPOA, and do a whole person center approach to health, and ensuring that this patient was in constant contact with his health providers. The other one, it's same thing. The member was being discharged, was discharged to a skilled nursing facility. At the nursing facility, they were doing some treatment that the doctor had specifically said that do not engage in this type of physical therapy yet. Um, and the community health worker came as a navigator, but also as an advocate to the needs and wants of the patient. Sometimes they don't know how to advocate for themselves, and they don't know the way to go about it. So in other words, the community health workers support that we can have the MPs having the introducing the MP, so the MP can provide the clinical support, but the CHWs and the chaplains can provide the social and the emotional part of the holistic approach to health. The way that we are able, as a value-based care organization, to support our program is through the share savings. So we are able to support these additional resources for our members without having to bill for it. Or a lot of the CHWs and other type of supporting resources normally are grant based. Our community health workers are totally able to be found by the value-based care savings. And so I know that we are probably a little bit short on time, so I'm just going to pass this to Lauriane so she has some time.
Thank you. I will take 1 minute because we are out of time, but I think I'll slide through some of the other slides I had ready for us. I wanted to present very high level or objectives. We know that we can't do health equity properly if we don't have appropriate data on the people that we serve, right? And so a focus for us is to really optimizing processes around data capture, ensuring that we are capturing race, ethnicity, language, disability, but as well as sexual orientation, gender identity. We've put a lot of work and training or resources around training providers. I think there's this assumption that patients don't want to be asked, but we also know that providers don't want to ask. They don't know how to ask, right? Those are questions that historically haven't been asked at the practice level. And so I think if we can bring together patients and providers, understanding why it's important that we understand more about who you are, because we can look into our own records and see if there's any health disparities amongst the patients that we support, right? So lots of resource around data capture. I think Dr. McWhorter talked about it. It's great to have your physician tell you eat healthy, right? But if the environment doesn't support you, if to have the tools to be healthy because you have proper streets and you have access to healthy foods and you feel comfortable walking or biking in your neighborhood, right? And the air you breathe is not full of pollution, right? It's becoming a lot more challenging. So at Equality, we really want to have a set of partnership with community-based organization in a way that's really supporting the populations that we mutually care for, the way that aligns with the community partners' vision. What is it that they really want to do, how they want to grow, but also in a way that aligns with the needs for the population that we serve. We do partner with closed loop referral system in the states that we're in. So in Texas, it's going to be Find Help. It's really grounded. Organizations are familiar with it. So for us, it's the opportunity to really further embed them into the system and finding a way to financially support organizations doing the work, because in value-based care, we'll be the one ripping off the benefits, right? But in the end, the health came really from the community perspective. We seek to support any local initiative that's happening. It's not about creating more silos rather than pulling resources together to really augment and enhance the work. And lastly, we plan to achieve health equity accreditation from the NCQA. I think this is something that I think 5, 6 Medicaid agencies are requiring MCOs to be health equity accredited. Arizona is certainly on the radar for that. And so we are gearing up for this work, and it's really exciting work. So I'll stop here. There's a lot more to say, but there's a little time for Q&A.
Thank you, everyone. I appreciate the presentations. Did anyone have any questions they wanted to ask? Feel free to either put it in the chat or unmute yourself.
I'll go first. Wes, yeah, thank you for all the great presentations. A lot of thought. I guess questions for Quality Health is I'm interested in sort of your business model in that you rely on primarily grants to provide these services, and if so, sort of what is the nature of your grants on the federal or state level?
Thank you, Dr. Parkinson. So my apologies if I wasn't clear in our operating model. We rely heavily on our value-based contracts that we source upstream with our payer partners. So we have a high risk sort of value-based payment contract that we have with our payer partners across all of our markets. That's our source. So obviously we're held at risk for how we perform on variable things such as quality measures. Those may vary across different contracts, and then also on how we perform from a total cost perspective. And so at the end of the contract year, we sort of do that sort of downstream financial reconciliation. And certainly if we're able to hit a number of those quality measures across those contracts, then that certainly funds a lot of the operating components of our model that Nora and Lauriane were speaking to, and the additional resources that we provide to our partners, to our providers within our physician network, Does that help? Now, I will say that from a grants perspective, we also have a 501c Equality Health Foundation that we also sort of have. And a lot of the work that the foundation does at the community at large does rely on grants. And then, as Lauriane mentioned, when we outsource community-based partners, a lot of those community-based partners do survive on grants, and so we're able to leverage some of the resources that we have to help them acquire some of those funding opportunities.
Denise?
Thank you.
Sorry, Doc.
Thanks so much. Good morning, everyone, and thanks for the great presentations. Dr. Onyiego, I have great to see you, by the way, but I have a question for you. Just, I'm curious with your Medicaid focus, if you all are targeting specific Medicaid populations, particularly here in Texas. We know that, with value-based care, time is kind of like of the essence, because you're taking on that risk along the full cycle of care. How does that work with such a fluid population kind of scenario, especially here in Texas with the Medicaid population?
Yeah, thank you so much for the question, Denise. It's a great one, and also good to see you as well. Yeah, I mean, I think that we are really looking at all lines of business across all of the Medicaid products. So that's Star Plus, CHIP, Star Health. So all of the lines of business, our model supports all of those populations. So we're again, in the work that we're doing upstream with the various payers, we're payer agnostic for a lot of these providers that are across the state. They, a lot of the advantage that we bring as a partner to these providers is the fact that they don't necessarily have to go into a portal for this payer, a portal for that payer, a portal for that payer, and it really streamlines a lot of the workflows and the efficiency so that they have one set of quality measures to work on for their entire population, regardless if that's a Medicaid population. Because as a clinician, and I'm still seeing patients, I'm not looking to see what plan they're on, what product they fall in, whether it's CHIP or Star. So we really try to take a lot of that off of the hands of the provider, but we don't, by far and away, our biggest product line for Medicaid is going to be our Star, but we certainly have supports within our model that allows us to take care of more complex products within Medicaid, like the Star Plus, and as Nora touched on, with our complex care program, because we have sort of a bridge, sort of program that allows us to really sort of serve some of these more complex patients who may not be engaging with their PCP. And so we're able to serve that population. So across the board, we're looking at it. Lauriane has been very vocal in terms of leading some of the work internally that we've been doing with the unwinding of the public health emergency. And so we've been tracking some of that influx and changes in membership. We're constantly sort of looking at where the population is going. How can we further assist in getting them re-engaged? So we're looking at all of the different approaches that we have, but we're not certainly honing in on one product of the Medicaid population. We're really trying to make sure that we're able to address the full scope.
And I'll just add one thing. One, that's why we think we're so unique, because the Medicaid population is so fluid, right? And so nobody wants to get in it because it's hard work. It's a lot of hard work. We did learn tremendously from the Medicaid unwinding around, what type of intervention can we do to support members just to stay covered, right? Like, do they actually understand? We are always excited when we see that there is a kind of 12 months continuous enrollment. Congrats, Texas, for doing this for maternal health, right? Those are exciting opportunities that we have to treat patients through a 12-month period, ensuring that they can have a healthy pregnancy, healthy post-pregnancy. So, but it's hard work, so.
Alina?
Thank you.
Hi, thank you for talking more about equality health. It's been really interesting to learn about. Lauriane, what are some of the challenges that you're facing in developing community partnerships in Texas?
Yeah, so I'll say we do have a position open for a community partnership manager, I think it's having boots on the ground. That's the number one piece. So we've had Dr. Onyiego very embedded in Texas. It's been great to have her start to do the connection. I think what we're seeing is, so first of all, there's already a lot of partnerships happening, and it's exciting to see. And I think it's being able to look at maybe how we can find common alignment. Unfortunately, so my background isn't in healthcare. I've been with Equality for 6 years, but I did community-based substance abuse prevention before. And so healthcare is great at coming and asking partners to help out, but not sharing the resources after, right? And so for us, it's really it's explaining how we're doing a different kind of partnership with our health entities. It's an opportunity for them to look at where is it that they really want to expand. And so finding the alignment, and sometimes it's just, maintaining relationship. There is not always the alignment at the time that we would want to have the alignment, but eventually through continuous conversation, looking at opportunities for organization to expand services or areas of that they hadn't considered, and maybe I see an opportunity. This is where we're continuing. So it's not quick work. I'm sure if you're asking the questions, you realize that, it's the trusting relationship is there. It's to find and to align the great alignment. So, but if you know somebody who's great in the community and in system thinking, we have a position open that's based in Houston.
Well, thank you for the great presentation. We're at time. And again, if you look in the chat, if you want to look up other past resources, and we'll post today's session as well there, or on our YouTube channel, and Mighty Networks, which is our communications platform. You can also post a job there if you all are on Mighty Network, Lauriane, as well. It's a good audience. Yep, but with that said, thank you, everyone. It's been another great session, and hope to see you at more Health Equity Collective events.
Thank you.
Thank you all.